Good afternoon, everyone. It is my distinct pleasure to welcome our first speaker today, Dr. Scott Berger, to Grand Rounds. Dr. Berger is an assistant professor and hospitalist at the University of Miami Miller School of Medicine. After getting his bachelor's degree in neuroscience and behavioral biology at Emory, he became what we sometimes refer to as a triple cane, doing his combined MD and PH training after earning a global health scholarship at the Miller School of Medicine, where he graduated in 2017. Then going on to do internal medicine residency at UM's Holy Cross affiliate through 2020. He briefly left us to do a fellowship in academic hospital medicine at the University of Washington Medical Center at Montlake, where he also held a faculty position as an acting instructor for the UW School of Medicine, then fortunately rejoined us as faculty in 2021. He has presented at local, regional, and national conferences on clinical, educational, and quality improvement topics in hospital medicine. We are delighted to welcome Dr. Berger, who will be presenting hospital medicine updates from the Society of Hospital Medicine in the past year.
All right. Thank you, Paul, for that really nice introduction. And it's an honor for me to be here to share some of the updates over the last 12 to 17 months in hospital medicine literature. Before I get started, I do want to acknowledge the presenters from Society of Hospital Medicine that introduced these articles to our department. So I want to give a shout out to Dr. Rahul Ganatra at Harvard and Dr. Heather Nye from the BA at the University of California, San Francisco. In the interest of time, I'm not going to go over all of the articles, but I'm going to go over the ones that I personally feel have been most strongly influenced my own practice and the patients that I'm managing day to day on the floors at UHealth Tower. So,
Scott, can you turn on your video camera so we can see you?
Yeah.
Thank you.
Can you see me?
Perfect.
All right.
Thank you.
No problem. All right. So I'm gonna skip over that slide, and I'm gonna go over a couple of hot button topics. And I wanted to start with heart failure because it's something that all of us, regardless of our specialty, see quite a bit of. And just a little context, we all know that we want all of our heart failure patients to be on goal-directed medical therapy. We not only want them on the correct doses, and when I talk about goal-directed medical therapy, I'm referring to the three big classes. I'm referring to beta blockers, that alphabet soup of ACE inhibitors, ARBs, ARNIs, and then mineralocorticoid corticoid receptor antagonists. We not only want them on these medications, but we want them on the correct doses. But some facts that I learned from looking into heart failure, we already know that it's a very common cause for admission. In fact, it's one of the top 5 reasons for hospital admissions, according to the CDC. But what I didn't know was that according to JACC as of 2018, less than 1/4 of all of our patients diagnosed with heart failure are actually on the goal-directed medical therapy, both the meds or the doses. And as inpatient providers, oftentimes we're the first ones to diagnose a patient with heart failure, or we're the first ones to realize in a patient with heart failure that they're not on the medications as recommended. And it's a pretty common occurrence where I'm the first person to prescribe any of these medications. So, and a lot of us experience a little bit of hesitancy because we're worried about complications. With beta blockers, we worry about dropping their heart rate, dropping their blood pressure. With the other medications, we worry about electrolyte complications or complications with creatinine and kidney function. So a lot of us wonder, how safe is it for us to rapidly up-titrate these medications to the goal-directed medication doses? So I wanted to introduce the first article, the Strong HF trial, which came out in Lancet last year, which answered that exact question. So I already reviewed why the studies are important, so I'm going to skip over those slides. So the Strong HF was a randomized control trial that looked at patients 18 to 85 with diagnosis of heart failure within 72 hours of admission. And this was patients were randomly sorted into either a high standard care treatment or high intensity care treatment, where patients were started on the optimal doses either in the admission or within 2 weeks after discharge, and were followed up with regular frequency at 1, 2, 3, and 6 weeks. And the outcome we were looking at was all-cause mortality or heart failure readmissions within 180 days. Secondary measures, they looked at quality of life as determined by a survey. So for those interested, I've included baseline characteristics, the tables with baseline characteristics to show that the characteristics of the patients in both groups were relatively similar in terms of their New York NYHA class, in terms of their ejection fraction, in terms of the number of them that were hospitalized, and a quick review of a couple of the evidence-based doses for goal-directed medical therapy. And this slide demonstrated that a lot of these patients were similar in terms of how many of them were on these medications prior to admission and prior to the start of the study. And this slide demonstrates how many of these patients at 180 days were on the optimal medication doses. And you can see that there's a much higher number in all three classes of medications in the high intensity group as opposed to the standard of care. In terms of the primary outcome, there was a significant difference in of all-cause deaths and heart failure readmissions in the high-intensity care. In fact, the absolute risk reduction was 0.66. In addition, they noticed that in terms of looking at secondary characteristics, patients in the high-intensity care group lost more weight, experienced a greater drop in their BNP, and were on lower doses of diuretics towards the end of the study. They did look at adverse outcomes, and while there were higher risk at 90 days of negative outcomes in high care intensity groups, they also looked at serious adverse events defined as patients with cardiac failure, sudden death, or viral pneumonia, and fatal adverse events. And they didn't see a significant difference in either one of those. So to me, I interpret that as, yes, we have to monitor for certain complications, but they're not usually life-threatening ones. The life-threatening ones are less severe in that, are not any more severe. So in terms of if I had to take away one thing from this article, we as inpatient providers should initiate a plan for rapid up titration. So what I do, I start my net as long as they're tolerating it from a vital sign standpoint and from a laboratory standpoint, I start them inpatient. And I make sure I know that who my patients are following up with within 1 to 2 weeks. If they're not established with cardiology, I will consult them, even though most of us know the goal-directed medical therapy guidelines and are able to start them. I do want to make sure that they have appropriate and prompt follow-up, which is my main reason for getting cardiology on board for a lot of these patients. Now, the next study we wanted to look at was the MPulse trial relating to SGLT2 inhibitors, because this is a newer recommendation from ACC, and a lot of us, including myself, trained at an era when these weren't the standard recommendation. So now we know that they're FDA approved because they've been shown to have a mortality benefit in all patients diagnosed with heart failure, regardless of their ejection fraction. But how heavily should we be pushing this on our patients while they're inpatient? So that's what the MPulse trial looked at. This was another randomized controlled trial published in Nature last year. They were looking at patients 18 and older diagnosed with acute heart failure, stabilized within 5 days. And specifically the SGLT2 inhibitor that they were looking at was empagliflozin. Again, here's some of and the outcome that they were assessing was a 90-day win ratio. And I'm going to define really briefly what that was. A win ratio was a composite outcome that the researchers looked into that included a couple of outcomes. Particularly, they wanted to know if patients died within the 90-day study period. They wanted to know if they experienced a heart failure exacerbation within that period, the time to that first exacerbation for those who did, as well, and whether or not they showed a symptomatic improvement as assessed by another survey. So again, baseline, all of these patients were similar in terms of their NYHA, ejection fraction, and also they made a point to include that these were similar patients with decompensated and acute de novo. For those who don't know, acute de novo are patients who are diagnosed on the admission with heart failure, who've never had a pre-existing diagnosis of it. So looking at the results, they did, in terms of the composite endpoint, they did show a more significant win ratio for patients in the experimental group as opposed to control. And they looked at secondary outcomes. They looked at the change in the quality of life survey at 90 days and also diuretic responsiveness at day 30, and those were shown to be as significant as well. Now, they also did a post hoc analysis, which I found was interesting enough that I wanted to include it. They looked at the survey for quality of life at day 15 And they showed a significant benefit here as well. So not only are we seeing a significant benefit in these patients' symptoms at the end of the study, that benefit was shown early as well. So what I take away from this trial is the main benefit for starting these patients on the inpatient setting is potentially that they might have a diuretic, an increased response to diuretics, and potentially we can get them on a lower dose of diuretics in a short period of time. But mainly they experience an improvement in symptoms and then we see it quickly. So that's what I tell my patients when I introduce this medication. And I would love, and if there's any cardiologists in the audience, I would love to know if there are recommendations for the other SGLT2 inhibitors other than empagliflozin, because empagliflozin and dapagliflozin are the only two that I use because those are the ones I've seen in the literature. So if anybody wants to message me afterwards, I would love to know. So I want to move on from heart failure now and discuss IV fluid administration. So this following study looked at fluid administration, particularly in patients with acute pancreatitis. Now, reasons why this is relevant, acute pancreatitis counts for about 300,000 admissions in the ED every year, and they're rising. About 20 to 30% of those patients progress and become moderate to severe cases. And the current recommendation that I think a lot of us learned is to be aggressive with fluids. And if we're following the guidelines, we end up giving a lot of patients anywhere upwards of 8 to 12 liters of fluid in a 24-hour period. And I can tell you a lot of the patients that I take care of here at UHealth Tower, a lot of them have other comorbidities. A lot of them have kidney issues, a lot of them have heart issues, and it's not uncommon to worry about these patients becoming volume overloaded and having complications related to that. So I found this study interesting because it's one of the first that looked at whether or not we can be a little bit more moderate in terms of our fluid administration. So this came out in New England Journal of Medicine last year. It's called the Waterfall Trial. We were looking at patients 18 and above within 24 hours of symptom onset with acute pancreatitis as defined by the revised Atlanta criteria, which I've included in the red box. And we were looking at how many of these patients progressed to moderate or severe pancreatitis within a 24-hour period. And they were also looking at secondary outcomes of length of stay, organ failure, ICU admission, progression of symptoms, and also they looked at a safety profile, particularly with volume overload. So briefly, I won't go into the nitty-gritty of this slide, but what we should know is that the patients in the experimental group, which is the moderate IV fluid resuscitation, were receiving about half as much fluid as those in the aggressive. And they also mentioned that some of these patients who were euvolemic on presentation did not necessarily need to get a bolus. So looking again, similar patient characteristics. One thing of interest is that this study was actually stopped early because they were seeing higher rates of volume overload in patients in the aggressive group, and there was some concern for patient safety. So the study was actually discontinued early. What they did show was that there wasn't a significant difference in those who progressed in the moderate group compared to those in the aggressive group. However, they did notice in the aggressive group, there were a higher rate of several different outcomes, particularly with respiratory failure, with complicated necrotizing pancreatitis, admission to the ICU, and symptoms during the admission. So this is the first study of its kind to suggest that, being less aggressive might actually be okay. There's not a significant difference in outcomes. However, being too aggressive does incur a higher risk of volume overload. So what do I take away from this study? I'm looking at these patients in the emergency room. I'm assessing their volume status. I'm assessing whether they're mild, moderate, or severe in terms of their classification for acute pancreatitis. And I would recommend that anybody taking care of patients and admitting a patient with acute pancreatitis, I recommend documenting whether it's mild, moderate, or severe. And I also recommend documenting the patient's volume status. Because one thing I found interesting, I'm used to bolusing patients when they come in through the emergency room. If somebody's euvolemic and mild, they might not need boluses. So that's what I would take away from this. Now, the next study I found interesting because this is one that doesn't necessarily change my approach to patients, but it's the first study of its kind that actually validated and provided some evidence to a practice that a lot of us here and the hospital medicine department at UHealth Tower practice. The big question is, are midlines better than PICC lines? So we have a lot of concerns about using PICC lines. Just intuitively, it makes sense to me that a midline would be safer. It's less invasive, and there's a lot of patients who have minor indications for venous access. Some of them just have difficult venous access. We have a lot of patients with renal complications who we don't want or for whatever reason have required multiple blood draws in the past, and they're difficult to get sticks on. In addition, we also have a lot of patients who require antibiotics when they're being discharged. We treat a lot of osteomyelitis. We treat a lot of endocarditis. We treat a lot of patients with multi-drug resistant infections that don't have an oral option. So it's very common every week that I'm here, there's at least one patient that I'm sending home with IV antibiotics. So it's relevant to us if we can get away with using a midline as opposed to using a PICC line. However, up until now, we haven't had any significant strong evidence that midlines are safer or reduce risk for certain complications. The common complications we think of being infection, blood clots, or difficulty with venous access through the line, meaning that we have luminal obstruction. And so this is the first study of its kind that gave us some answers to that question. And this came out in JAMA of Internal Medicine back in January of 2022. The study was done out of Michigan. It was a retrospective cohort looking at patients 18 and older who were either admitted to an inpatient service or an ICU and had either difficult venous access or required IV antibiotics for a course of 30 days or less. And we were looking at major complications. The three major complications we were looking at was symptomatic DVT or PE, bloodstream infection, or luminal occlusion of the line. So again, baseline characteristics, these patients were pretty similar. And looking at the composite outcome, this was the first to show that patients admitted with midlines had a lower rate of complications compared to those with PICC lines. And if we break down each of them, the three composite endpoints individually, we did see a lower rate of bloodstream infections and luminal occlusion, but not of DVTs. Now they also looked at a secondary endpoint of hazard ratio for these patients with DVT, particularly the number of DVTs and the total number of catheter days. And they did see that the hazard ratio was pretty significantly not as great for patients with PICC lines. So this might not have the strongest evidence to support the use of a midline. However, it's the first of its kind and probably the most robust of its kind to show that midlines do have lower rates of certain complications. So this is the first this is the first article that I've looked at that kind of reinforces what a lot of us believe, which is that midlines reduce the risk of certain complications. So if I can get away with using a midline instead of a PICC line, I try to do that. So the last article I'm going to cover, I think I'm going to cut it off here just in the interest of time, is I wanted to look at this article that came out about antibiotic administration. So the big question is we have a lot of patients that we are admitted with suspected bloodstream infections, or we think are infected, and we're ruling out a bloodstream infection. And oftentimes the standard of practice for a lot of hospitalists, broad spectrum antibiotics. We look for gram-positive coverage, we look for gram-negative coverage. So the big flavor, we usually start with vancomycin and either a beta-lactam to cover gram-negatives. Usually that's either cefepime, meropenem, or piperacillin tazobactam. I tend to use cefepime, that's what I see most of us use here. And one thing that not a lot of us think about is which one should we administer first? If we have to start with one, which should come first in terms of the sequence of administration? So we know that timely antibiotics save lives. And for those who might not know, if I didn't necessarily know the data before reading this article, gram-negative infections tend to be a little bit more deadly than gram-positive. And one thing that you might not know, if you spend a little bit of time with your nurses, they may tell you that that administering a beta-lactam takes about 15 minutes for infusion, but vancomycin takes a little bit longer. It takes an hour. So if we're starting with vancomycin, we're delaying a little bit more significantly our gram-negative coverage. So there's a lot of reasons why this is relevant for us as hospitalists. Which one should we instruct our nurses to give first? So this study looked at looked at patients at 13 and older admitted to the inpatient setting with a diagnosis of bloodstream infection who got both vancomycin and a beta-lactam, and they looked at those 3 antibiotics that I just mentioned. And they were looking at an outcome of death within 7 days from a bloodstream infection, and secondary endpoints they were looking at was death within 48 hours. And they also looked at a subgroup of patients who were diagnosed with MRSA bloodstream infection. So looking again, similar baseline characteristics, the major outcome we were looking at showed an unadjusted OR and an adjusted OR that was significantly showing in favor of giving the beta-lactam first. And an interesting, looking at that secondary outpoint, they actually show that when there was no harm caused to patients who were diagnosed with a MRSA bacteremia in delaying vancomycin in favor of the beta-lactam. So the big takeaway is if we have to instruct our nurses to give one of these medications first, I would encourage them to give the beta-lactam first and start with gram-negative coverage. All right, so I do have, in the interest of time, I think I'm going to cut it off there. And thank you very much for your time.
Thank you, Scott, for that very organized and well-presented summary of some of the hot topics in hospital medicine that you deal with on an everyday basis. And it was very informative. Thank you. I'll open up the paper to discussion. Dr. Soares.
Thank you. Thank you, Dr. Berger. Thank you, Scott, for a great presentation. I think the important thing is that it highlights all the great work and all the different types of work that are being done by hospital medicine. Do you think, Dr. Berger, for you, what would you think is how do you reconcile all of these decisions that you make in terms of what is it that you're able to manage and how do you communicate with your consultants? So when do you draw that line? This is a relatively vague question.
Well, a lot of these cases, a lot of us are well equipped with managing, but I think particularly with heart failure, my biggest reason to call the consultants is I'm always worried about what's going to happen with my patient when they leave the hospital. I'm certainly comfortable starting a lot of the medications and starting treatment and monitoring them on an inpatient basis, but my big concern is what's going to happen when they leave the hospital. So that's one of the big things I look for when I'm calling a consultant. I'm looking for them to help me with follow-up because I'm not the one who's going to be able to follow these patients up once they leave the hospital. And the goal is once they leave the hospital, we want them to stay out of the hospital. We don't want them coming back. So that's where I really look to my consultants is to help me set up their follow-up and make sure that they stay safe moving forward.
Thank you. Any other questions? Wonderful. Let's move on, Dr. Montana. Thank you, Dr. Berger.
Thank you.
Thank you so much, Dr. Berger. Really helpful talk for myself and I'm sure for the residents as well as, of course, the faculty. So it's now my honor to introduce our second speaker, Dr. Morgan Carbajal, to Grand Rounds. Dr. Carbajal joined the University of Miami Department of Medicine faculty in 2022 in the Division of Pulmonary Critical Care and Sleep Medicine and sees patients as both an inpatient and an outpatient provider. She also received her combined MD, MPH training, but went to the Tulane University School of Medicine as well as the Tulane School of Public Health and Tropical Medicine as a merit scholar. She then went to the University of California at Davis for residency in internal medicine, and then made another cross-country move to the University of Vermont for Pulmonary and Critical Care Fellowship, where she performed research in viral-induced lung injury and ventilator-induced lung injury. And also she received professional accolades for her work as an educator there. She continues educating here at Miller, teaching medical students and residents on topics ranging from pulmonary function testing to point-of-care ultrasound and seizure management in the intensive care unit, among other topics. Her current clinical and research focus is on pulmonary vascular disease. And in that light, we are extremely excited to hear her talk today on clinical highlights of pulmonary arterial hypertension. Thank you so much, Dr. Carbajal.
Thank you. Thank you for that introduction and thank you for the invitation. I'm going to share my screen. All right. So as mentioned, I'm going to talk about a case today of pulmonary arterial hypertension, and I have no disclosures. So the case starts, I'll start with our objectives. So first of all, the purpose of this talk is to help identify the clinical presentation, risk factors, and high-risk features of patients who have WHO Group 1 pulmonary arterial hypertension. That's going to allow us to become familiar with the diagnostic workup and risk stratification process when we evaluate a patient with PAH. And then you should be able to discuss the impact of PAH on a patient's quality of life, reproductive health, and psychosocial well-being. So this is a case of a 20-year-old adopted woman with a history of ADHD who came to my clinic with several months of progressive dyspnea on exertion, intermittent chest pain, and pre-syncope on exertion, and also when she would take a shower. She had had previously multiple ED visits before being referred to a cardiologist, who eventually did an echocardiogram. And this cardiogram showed that she had evidence of pulmonary hypertension. She appropriately underwent right heart catheterization in an outside institution, which showed that she had a mean pulmonary arterial pressure of 45 millimeters of mercury and a pulmonary vascular resistance of 7 Woods units. And for that reason, she was referred to UM for management of WHO Group 1 pulmonary arterial hypertension. So when she reported also accelerating daily symptoms of pre-syncope palpitations and chest pain on exertion. She knew that her biological mother used methamphetamines while the mother was pregnant, but the patient also had a personal history of using amphetamine-based medications for ADHD, but she was not currently using them. So that brings us to the first clinical question, which is, what is the pathophysiology of pulmonary arterial hypertension, and how does that relate to the clinical presentation? So I'm sure many of you are familiar with the WHO pulmonary hypertension groups 1 through 5. The most common group worldwide is WHO Group 2 PH, which is associated with left heart disease, and that makes up about 70 to 80% actually of pulmonary hypertension patients. And with the second most common group being the PH associated with lung disease, WHO Group 3 pulmonary hypertension. After that, the remaining cases of PH are due to chronic thromboembolic disease, or CTEPH, and with the smallest groups being pulmonary arterial hypertension. So keep in mind, pulmonary arterial hypertension only refers to Group 1 PH, as well as those causes that are either multifactorial or have unknown mechanisms. Those fall into WHO Group 5 pulmonary hypertension. So this patient was diagnosed with Group 1 pulmonary hypertension, and we're going to focus in quite a bit on that now. So although we're all familiar with the 5 groups, a lot of the literature and the practice of pulmonary vascular disease is actually moving towards a more physiologic-based categorization of pulmonary hypertension types. So now we have a physiologic dichotomy between pre-capillary pulmonary hypertension and post-capillary pulmonary hypertension. So post-capillary would include your WHO Group 2 patients, those with left heart disease, as well as some of the Group 5 patients. And pre-capillary is what is made up of the Group 1 patients, as well as Group 3 from chronic lung disease and hypoxia, Group 4 from occlusive pulmonary arterial disease from thromboemboli, and also some of the other Group 5 subgroups. So the criteria for pre-capillary disease is that you have a median pulmonary arterial pressure of greater than 20 millimeters of mercury, a wedge pressure, which is an estimation of the end diastolic left-sided pressures of the heart, which is less than 15, and then a pulmonary vascular resistance of greater than 2 Woods units. And you'll notice a discrepancy between the 2 and the 3 Woods units. We use 3 as the cutoff for treating with pulmonary vasodilators, whereas you only have to have a pulmonary vascular resistance of 2 to be diagnosed with pre-capillary pulmonary hypertension. When I explain this to patients and also to trainees, I use an analogy of a garden hose. So with your post-capillary patients, it's analogous to putting a nozzle on the end of the hose. If you increase the resistance at the end of the hose, the proximal pressures are going to rise. Whereas if you increase the resistance, like in the middle frame, increase the resistance in the vessels themselves, you're also going to have increased pressure. And so these rules are based on Ohm's law, which you'll remember V equals IR, or the pressure inside of the hose is equal to the flow through the hose times the resistance. So that also means that the flow is going to be dependent itself on the resistance. And if you increase the resistance, you're going to have a decrease in the overall flow through the vascular bed. And so the third mechanism of increasing pulmonary vascular resistance actually has to do with the high output state. So if you look at the fire hydrant on the right, if you push very high flows, like for example, from a high cardiac output state or from a very large AV fistula for dialysis, that's also going to drive the pressure within the pulmonary vascular bed upwards. So the WHO Group 1 pulmonary arterial hypertension can be derived from multiple different etiologies. So the most common etiology is actually idiopathic, and we divide those folks into the vasoreactive non-responders and then the acute responders to vasoreactivity testing. And that's a perioperative or intraoperative test that we do during right heart catheterization to see whether they're going to respond favorably to calcium channel blockers and whether they'll be eligible for treatment with calcium channel blockers. Among heritable disease, the BMPR2 is the most common genetic mutation that's known associated with PAH. And then drugs and toxins are also quite common. So in areas with endemic methamphetamine use, these patients can make up a large portion of the PH practices for a lot of providers, but also in our patients who with cancers and history of chemotherapy, the tyrosine kinase inhibitors are also associated with PAH. Underlying diseases like connective tissue disease, HIV, portal hypertension, congenital heart disease, and globally schistosomiasis are all associated with pulmonary arterial disease. And these are disease states that we screen for when we first learn that a patient has PAH. Pulmonary vaso-occlusive disease and pulmonary capillary hemangiomatosis are very small subgroups of PAH with specific vasculopathies. And then pediatric PH can be found in patients with congenital heart defects. They can also have idiopathic and heritable PAH. So what all of these etiologies have in common is that they disrupt the pathways pertaining to endothelial derived factors like nitric oxide, endothelin, and prostacyclin. And with those interrupted pathways, you end up with an imbalance between vasodilation and vasoconstriction in the pulmonary vascular bed. So with that, you also have inappropriate increase in cellular proliferation within the blood vessels, which can lead to these obstructive or occlusive lesions on the histopathologic level. And so it's that mechanism which leads to increased pulmonary vascular resistance. And that increase in resistance and thereby pressure will lead to your symptoms. So VQ mismatching as a result of these lesions leads to dyspnea on exertion and fatigue, but there can also be more mechanical symptoms in the later stages. So you'll have patients tell you that they have severe palpitations, like their heart is going to explode because of the physical distension of the vessels. Also exertional chest pain from dynamic compression of the left main coronary artery can lead to anginal symptoms. And then patients can actually present with airways mimicking disease, like shortness of breath or wheezing, because there's actual compression of the bronchi by the dilated vessels. So that brings us to the second clinical question, which is, what is this patient's risk of death resulting from PAH, and how does that guide our next step? So we categorize patients by functional class, first of all, and the WHO functional assessment classifications, or WHO functional classes, are very akin to the New York Heart Association classes for heart failure. So a patient with class 1 functional status is going to have very good functional status without limitation of physical activity, and even significant activity like riding a bike doesn't cause undue fatigue or chest pain or symptoms like near syncope. But on the flip side, a patient with class 4 symptoms, they're not going to be able to carry out any of their regular activities. They have symptoms sometimes at rest, but also with simple tasks like doing the laundry or taking a shower. These patients often have signs of right heart failure, like edema and cyanosis as well. So in addition to the functional classes, which filter into our risk calculators, the REVEAL 2.0 score is one of the most validated and is the latest iteration of a risk calculator that we use. And this is important because a patient's risk class is really going to determine their therapy and how aggressively we up-titrate them. So the REVEAL score has a very strong ability to discriminate between risk classes with good sensitivity and very strong specificity. So we're not over or under calling a lot of patients when we say that they're low risk or high risk. And you can see that a low risk patient is going to have, somewhere on the order of 0 to 5% mortality risk, or 5% would be more of an intermediate patient. But anything above 8 or 9% mortality is considered high risk. And that range can go up to over 50% risk when their scores are greater than 13 on this calculator. So you'll see variables in the calculator include their WHO group 1 subgroup, whether they have connective tissue disease or heritable disease, for example. Males over 60 are higher risk, their functional class, vital signs, hospitalizations, their distance on a 6-minute walk, and lastly, a pericardial effusion on an echocardiogram. These are all important factors in the calculator. So most pulmonary hypertension patients with pulmonary arterial disease are going to end up on a combination of either a PDE5 inhibitor or an endothelin receptor agonist plus minus prostacyclin analog. So combination therapy is the mainstay, and the number of agents that a patient is on is largely determined by their risk status. So for many years, combination therapy was actually initiated in a stepwise fashion. So they would start on monotherapy with a PDE5 inhibitor like sildenafil or tadalafil, and then some kind of treatment failure or lack of adequate response would have to take place before they were escalated to a second agent or a third agent. But there was quite a paradigm shift in 2015 following the AMBITION trial, which looked at WHO functional class 2 and 3 patients and started the experimental group on upfront dual therapy with tadalafil and ambrisentan. And this was found to decrease the risk of clinical failure events compared to just monotherapy with the PDE5 inhibitor alone. And so now in more recent years since then, it seems like the literature is really moving towards even more aggressive up-titration in the intermediate risk groups, up-titration of the dual therapy, and then having a very low threshold to start a third agent with a prostacyclin analog like epoprostenol or treprostinil. So to come back to the patient, she had a functional class, a WHO functional class of 2 on presentation, but even she was functioning fairly normally, due to the delayed presentation and multiple barriers to efficient care, the decision was made to admit her to the hospital and obtain further workup and initiation of treatment. So the first test that she underwent was a CTA of the chest, and you can see on the left that she was found to have diffuse mosaicism. So we commonly associate mosaic attenuation on the chest CT with airways disease or obstructive disease, and that was just not the case. More likely, this was due to diffuse VQ mismatching from diffuse vascular pruning. And then on the right, you can see her pulmonary artery, even though it only measures 2.8 centimeters in diameter, it's still over ½ a centimeter larger than her aorta. So this also meets criteria for pulmonary arterial enlargement, is it's very suggestive of pulmonary arterial hypertension. And she was not found to have any pulmonary emboli. So this is a portion of her ventilation perfusion scan, and we do this routinely in all PH patients to rule out chronic thromboembolic disease, which is not always evident on a CTA. And although she doesn't have any of the typical wedge-like infarcts here on her perfusion scan, what you can appreciate is that she has a lot of diffuse heterogeneity mainly around the periphery of the lungs, but this is also indicative of that vascular pruning that takes place and extensive VQ mismatching. And these were not matched on her ventilation scan. So unfortunately, the video for the echocardiogram is not functional in this setup right now, but her first echocardiogram, she was found to have an ejection fraction that was normal, and her right ventricle was still in normal in size and function with a normal TAPSE. But her right ventricular systolic pressure was measured to be slightly increased at 40 to 45 millimeters of mercury, and she did not have a pericardial effusion. And remember that's an important factor in that REVEAL risk calculator. She was noted to have a septal bounce, which is commonly seen in constricted pericarditis, but the clinical significance of that finding was not determined at the time. So of course she underwent right heart catheterization, and this test is mandatory for the diagnosis of pulmonary arterial hypertension. And what it does is it directly measures the intracardiac pressures of the right atrium and ventricle, as well as the pulmonary arterial pressure and the pulmonary capillary wedge pressure, our proxy measure for the left ventricular and diastolic pressure. So you can see on the bottom that her mean PA pressure was elevated at 46 and her wedge was normal at 5. So she's meeting 2 of the 3 criteria for pre-capillary pulmonary hypertension, but what was her pulmonary vascular resistance? So what is the pulmonary vascular resistance at all? What it is based on the transpulmonary gradient, which is the change in pressure across from the pulmonary artery to the LVEDP. And that difference in her was 39 millimeters of mercury when divided by the cardiac output, which was measured by the Fick equation, came out to approximately 6 Woods units. So definitely greater than the cutoff of 3 Woods units to meet criteria for treatable pulmonary arterial hypertension. Therefore, she was started on sildenafil while we waited for insurance coverage to come through on her macitentan, her second agent, the endothelial receptor antagonist. Meanwhile, she received an urgent referral to OBGYN for pregnancy prevention. And this is important because maternal and infant mortality are very high in pulmonary hypertension. So historically, there's been measured up to 56 maternal mortality and 13% infant mortality in secondary PH, and now up to 25% of maternal 25% maternal mortality in pulmonary arterial hypertension, group 1, and that's even with the therapies that we have today. So therefore, guidelines actually recommend permanent pregnancy prevention via sterilization for patients with pulmonary arterial hypertension, and that therapeutic abortion should actually be offered if right heart failure is detected in the first trimester in someone who does become pregnant with PAH. And so with all this in mind, it's really important to know that the emotional burden of these facts for the patient is huge and should be addressed head on from the very first meeting of the patient. It's also important to discuss that multiple first-line therapies for pulmonary arterial hypertension are teratogenic. That includes the ERAs and the guanylate cyclase inhibitors. And these are, first-line drugs for PAH. So and just another reason that contraception is so critical. Not all contraceptive methods are safe in PAH because many of the estrogens actually risk worsening PAH from the effect of sex hormones on the pulmonary vasculature. But also remember, estrogen is associated with a hypercoagulable state, and these patients do not tolerate pulmonary emboli very well. So again, early conversations and early referral for contraception and early alternative family planning are really critical to the well-being of these patients. So our patient, after starting sildenafil, actually did incredibly well. She came to her first appointment and said she was riding a bike. She was therefore WHO functional class 1 at that point. However, her symptoms started to recur after several weeks on the sildenafil while we were waiting for her second agent. And in that time, she had had a progesterone IUD placed. She managed to lose 2 units of blood secondary to some untoward bleeding after getting the IUD put in. And after that, she started to develop more dyspnea and chest pain, but then she informed me that she was going to take a flight to a family gathering. And then, although she was advised not to go on the plane, she did take an oximeter with her, and she was desaturating to high 70s while on the plane. She felt like her heart was going to explode out of her chest. She made it back home and started on the macitentan, but also needed home O2 at that point and started to develop WHO class 4 symptoms. For that reason, she was readmitted to the hospital for initiation of continuous prostacyclin IV therapy. So her follow-up echocardiogram on the right, I have the initial one on the left, but on the right, you can see just in this still frame that her RV is now more dilated than previously. The systolic function was still preserved, but her septum was also flattened, indicating right ventricular volume overload. So she was in a bad spot when she was readmitted to the hospital. So that brings us to our last clinical question, which is, why did she deteriorate while on therapy? So the first explanation could be that she just didn't have enough pulmonary vasodilation from the get-go, and then the blood loss and air travel accelerated her into a pulmonary hypertensive crisis. But explanation number 2 also came to mind, and that would have been worse if she had underlying undetected pulmonary vaso-occlusive disease, which actually results in post-capillary physiology because the obstruction is on the venous side. This would result in a poor response to pulmonary vasodilators and require immediate cessation of drugs and transplant referral. Fortunately, she was admitted. She was started on IV prostacyclins, which would be the only way to determine which of these 2 processes had actually taken place. And within a few days was walking the halls of the hospital asking to go home. She was back to a functional class of 1 within a few days. We were able to transition her to a subcutaneous infusion via wearable pump, and she was discharged home on this. So to conclude, WHO Group 1 PAH is a very rare but also very high mortality diagnosis that can be very easily missed. Early recognition, risk stratification, and referral to a PH center is critical. And then lastly, PAH can have a very profound impact on the psychosocial well-being of patients. And so focusing attention on these issues will actually likely affect their survival. So that's all that I have. I want to thank Dr. Weiss and Dr. Punjabi for inviting me, and also thank all the providers that were involved in this case. I know a lot of you actually met the patient or interpreted her echo, and she's actually had a good outcome so far. So I appreciate everyone.
Thank you, Dr. Carbajal. That was a great presentation, very clear and very important teaching points here. Going back to the issue of sex hormone influence on PAH, from a perspective of, I understand from a perspective of contraception, there are obviously alternatives, but to estrogen therapy, and obviously not indicated in these patients. But is there any reason that you would want to lower the estrogen levels below physiologic levels in women that are of reproductive age? And on the converse, what about men? Is there any evidence that testosterone in men is problematic in PAH?
Yeah, those are great questions, and definitely the topic of growing literature and increasing research efforts. In terms of the estrogens, my understanding is the one that is most well known and studied is DHEA levels, which when, oh boy, I don't even want to say if it's high or low DHEA, but that is the one that's most closely associated with the development of pulmonary arterial hypertension, but I don't know that there's been any effort to suppress certain sex hormones for the treatment. And I think we're still in kind of a physiologic exploration type of phase in regard to that research. And then with regard to testosterone, that I am not really sure about. I do know that pulmonary arterial hypertension can occur in the setting of anabolic steroid use, which may be associated with changes in male sex hormones and androgens, but that body of literature is not my area of expertise.
Thank you. Any other questions from the faculty or house staff, students? Dr. Punjabi, you have unsilenced your microphone. Did you have a comment?
Yeah. Hey, Morgan, great presentation on PAH. Question for you, and I think some germane to the community that's present here. Secondary PAH, let's say to COPD. What are your thoughts about management of pulmonary hypertension? And let's specifically focus on COPD itself. All of us see it. These people who have substantial ventilatory impairment, nocturnal hypoxemia, and of course they have elevated pulmonary artery pressures. How is that management? Is it focused on primary disease, or start thinking about pH? Related to or the armamentarium of pH related medications.
Yeah, so with COPD specifically, a lot of the pulmonary vasodilator trials have been very negative. So as opposed to with ILD, in which we have inhaled treprostinil, which improves people's 6-minute walk tests with inhaled treprostinil, which is, an inhaled pulmonary vasodilator. So the literature on COPD do not support the use of pulmonary vasodilators, and the management is very focused on management of the underlying disease, the hypoxia, the chronic hypoventilation, and those kinds of issues. So I think, I tend to focus on, these folks tend to have very severe COPD, getting all those adjunctive therapies on board, like their nocturnal non-invasive ventilation and, other kind of second and third line medical therapies for COPD to prevent exacerbations are really important.
Thank you, because I do see people that have got, the inhibitors on, despite the fact that they've got this unrelated, the COPD related etiology of their pH. Thank you for that.
Yeah, I think the literature has largely not supported that practice.
Great. Dr. Chung. ILD question, I'm sure, related to PAH.
Not exactly,
Okay.
right. But Morgan, thank you for that wonderful presentation. Because from a practical standpoint, in rheumatology, we tend to follow our patients with periodic, high-risk patients with periodic echoes. And I've heard different kind of points from different pulmonologists, cardiologists in terms of when to refer these patients for further evaluation. Could you please comment on that? What are your recommendations?
So I would say for a patient that does not have known pulmonary hypertension, but on a screening,
exactly, you get an RVSP, like do you have a kind of point, or what do you recommend?
I feel like, and this is my personal opinion, but even without an elevated RVSP, if you see any changes because you can have changes to the right ventricle or even the right atrium with chronically elevated pressures, if you're seeing those kind of, anatomic changes to any kind of abnormality in the right heart, I would go ahead and refer. The first sign of an elevated RVSP, I would go ahead and refer. The echocardiogram tends to overcall the pressure more than undercall in comparison to right heart catheterization, but still, we have patients who have exercise-induced pulmonary hypertension that wouldn't otherwise be detected on an echocardiogram. And there are patients not with, because a lot of, autoimmune disorders are associated with hypercoagulable states, patients with not chronic thromboembolic pulmonary hypertension, but chronic thromboembolic pulmonary disease, where their dyspnea is still related to chronic thromboembolic disease, but they don't have the pulmonary hypertension to accompany that. And that still falls within the realm of pulmonary vascular disease management. So I would have a very low threshold to refer, not only for elevated RVSP, but any abnormality seen on the right side of the heart, including the right atrium. And then any other, if they have a dilated PA on a CT scan, I see that a lot without any necessary echocardiographic changes. Just any little hint can suggest that there's some kind of abnormal physiology. And the earlier that you catch people, they're better off they're going to be, even if it's just to be monitored over time in by a PH specialist. To get the right heart cath or to get a right heart cath with exercise can be really, save that patient years of going undiagnosed or, not receiving treatment.
Thank you. I'd like to thank both our speakers, Dr. Berger and Dr. Carbajal, for very nice presentations. And I remind everyone to look in the chat for the link to the CME and MOC credits, and wish everybody a wonderful and safe day, and we'll see you next week. Thank you.